Welcome. This is Casebook Consults, Improving Outcomes in Gout. I'm Dr. Paul Doghramji. I am a family physician at Collegeville Family Practice in Collegeville, Pennsylvania. I'm also Medical Director of Health Services at Ursinus College, also in Collegeville, Pennsylvania. Joining me on this program and as panel discussants is Dr. Brian Mendel, Chairman of Medicine and Rheumatology at the Cleveland Clinic. Hello, Brian.
Paul.
And with us also today is Rick Pope, Adjunct Professor in the Department of Physician Assistant Studies at Quinnipiac University in Connecticut. Welcome, Rick.
Hi, Paul.
All right, let's get right into it. Hyperuricemia and gout. What is hyperuricemia? Well, of course, quite simply, it's high levels of uric acid in the blood. And this can occur either due to uric acid overproduction, or it can occur as a result of underexcretion, which is the most common reason. And we call uric acid elevation when it's 6.8 milligrams per deciliter or above, which is, of course, a physiochemical number. Serum uric acid level 6.8 or above. This number is going to come out quite a bit, gentlemen, in our talk as we go on. Numbers are very important when you talk about uric acid. So gout. This results from tissue deposition of monosodium urate crystals that can occur when the number is 6.8 or above. Now let's talk a little bit about uric acid and what contributes to it and also to its elevation. First, of course, is our production of uric acid. Uric acid is a breakdown product of nucleic acids. So this purine synthesis, it's endogenous, we all make some. In some situations, there is overproduction of uric acid. There is more purine synthesis that occurs, and this can contribute to higher levels. There can also be a higher dietary load if we eat a lot of foods rich in purines. We're going to talk about which foods contribute to it. As a general rule, it's not that big of a contributor, but it can be in certain instances. Then there's renal excretion. The great majority of uric acid is excreted in the kidneys. And in situations where the kidneys don't secrete that well, we can have a rising level of uric acid. Now, the gut also contributes somewhat to getting rid of uric acid, but when the levels rise, the gut can't manage how much uric acid is being produced. And as a result, urate supersaturation and crystallization occurs. This supersaturation occurs in the entire body. Every square inch of our body does have elevations of uric acid when our levels are 6.8 or above. But of course, most ominous is when it accumulates in joints and it crystallizes in joints and causing these crystals to cause an inflammatory process, which we're going to go through in detail in a few moments. So there's a direct causal relationship between serum uric acid level and the risk for gout. The higher the uric acid, the higher the levels or the probability of gouty attacks occurring. So gout is an inflammatory process in the joints or periarticular tissue, again resulting from the deposition of monosodium urate crystals. Now, tophi. Tophi is where uric acid deposits in soft tissue to the extent that as the years go on, it produces small, then eventually enlarging nodules. And because uric acid will crystallize at lower temperatures, they tend to occur more in areas where there are lower temperatures. And these are the digits, the fingers, the toes, and also the ears. So these are soft, painless nodules that can occur in areas, and as the years go on, as I said, they can enlarge. So the accumulation of uric acid crystal in soft tissue then is going to cause these tophi. Now they can be crippling, they can be disfiguring as seen in these pictures, and one interesting thing is when left untreated after a gouty attack, 75% of patients will develop visible tophi within 20 years. And it's way too late as far as treatment goes when we see these tophi developing. Another thing that can happen is chronic arthropathy, which we often don't consider. We think that if you're getting a uric acid crystallization in the joints causing an attack, the periods in between are no big deal. But actually, and Brian is going to talk a lot more about this later, but these intercritical periods, these time periods where there's no attack going on, there still is damage occurring as a result of that supersaturation, that excessive amount of uric acid in these joints. And finally, recurrent kidney stones can occur. With all this uric acid going through the urinary tract and into the urine, we can have kidney stones that are also occurring, so nephrolithiasis. Now, an interesting thing which we often don't consider, but we absolutely need to, is that uric acid does have cardiovascular concerns. Okay? What we have found is that the higher the uric acid, the more probability there is of hypertension occurring. We also see that there's coronary artery disease. The higher the uric acid level, it can contribute to coronary artery disease and also chronic kidney disease. These three are very important, gentlemen, when we talk about uric acid, but what we don't know for sure is that if we lower uric acid, are these conditions going to be mitigated? So as a result of these, we can have acute myocardial infarctions, cardiovascular mortality, and even stroke. So as the years go on, we're probably going to be a lot more concerned about uric acid if we have studies that show that when we lower uric acid, we can possibly cause some kind of an improvement in these outcomes. So what are the risk factors then, and what are the common comorbidities for hyperuricemia and gout? Well, the most important thing that you need to know about is metabolic syndrome. When you see a patient with metabolic syndrome, the probability of gout in that person is extremely high. Now we know that with metabolic syndrome we have obesity, we have hypertension, we have insulin resistance, we also have a specific kind of dyslipidemia with low HDLs and high triglycerides. These are the metabolic syndrome people that we're looking at that can have a substantially high probability of hyperuricemia and gout. These patients also have a higher rate of obstructive sleep apnea. These are some of the comorbidities then that contribute to hyperuricemia. There's also lifestyle issues. Patients with high purine diets, high meat content, like seafood, high fructose beverages. We also always talk about our patients that have hyperuricemia with respect to beer. But we also should know that it's not just beer, but certain other types of alcohol can also contribute, like distilled spirits can do it, and wine to a certain extent. So in order of worsening, beer is the worst, followed by distilled spirits and then wine. It turns out that inactivity is also an issue. Well, we all have a challenge in having our patients try to get them to exercise and, of course, eat better. It is a challenge, but lifestyle changes can make a little bit of a difference in our patients when they have hyperuricemia. Now, one of the other factors that we actually are involved in towards our patients having hyperuricemia is what we give them. Medications like diuretics, thiazide diuretics, loop diuretics, these medications can increase the amount of uric acid in the serum and can cause worsening hyperuricemia. Low-dose aspirin, it's very important for our patients in preventing them from cardiovascular disease. Cyclosporine, anti-tuberculous antibiotics, niacin, which of course we use in patients with metabolic syndrome, can also contribute to hyperuricemia. I think that the key feature here is the key thing that we have to think about is the risk-benefit situation. So as far as non-modifiable risk factors, folks, we all know this, that the older we get, the higher that we have a probability of developing hyperuricemia. But men have a higher probability, but this occurs only until menopause. Estrogen tends to be very beneficial in lowering uric acid. So after menopause, and as the years go on, the rate of hyperuricemia and gout equals that of men in similar age. Genetics, very, very high probability of gout occurring in family members as they go on. So we have to look for this when we ask our patients about gout. We always have to ask about family history, and certain ethnic backgrounds are also more at risk of hyperuricemia. Now let's have a case discussion, a patient case. We're going to call her Janet. She is a 65-year-old postmenopausal woman, and she presents with a painful, erythematous, red, swollen mid-right foot. And she says that it really hurts to walk on it. She's walking into your office, she's really limping. She's had a slight fever, low-grade fever, around 99 or so. Her BMI is elevated, it's 31, so it puts her in the obese category. She has an elevated fasting blood glucose as one of the past medical issues with her. She's not diabetic, but she has impaired fasting glucose. She has hypertension, and she is being controlled on hydrochlorothiazide, 25 milligrams per day, and has been for several years. She's also receiving niacin, 1,000 milligrams. She's tolerating it quite well for her dyslipidemia, hyperlipidemia, where she has low HDL, high triglycerides. All right, so let's take a look at Janet, gentlemen. Let's see how she comes in with and how she presents.